technologies and all that. And at the end of the day, see how we can make use of these facilities as they evolve. I know it may be expensive, as it were, but with time, I think we'll be able to get there. Once again, thank you very much.
Thank you, sir. Sir, the next session is on anomalies scanning. It's going to be handled by Doctors Enabudozo, Awowole, and Akimoladu. Precious, can you please take down your slides, please? They are here. Professor Tuk, you also chaired this session for us. Dr. Ramon will join you, sir. Thank you so much, sir.
Okay, thank you very much. Sorry. Once again, let me welcome everybody into this second session. And I welcome the presenters. Happy to know that they're already here, prepared for the job. And I know that ultrasound has come to stay and no running away from it. If you're not there, then you should find a way to fix yourself in. And it's a session that I believe all the participants will learn, all the participants will derive something at the end of the day. And I thank the presenters for coming in, and I call on them at this moment to take the floor. Thank you very much.
Good morning to everybody. I'm Ibrahim Awole from the Obafemi Awolowo University Teaching Hospital, Ife. It's a great pleasure to be attending this session. I must especially say good morning to all our teachers and very senior professors on the platform. Your presence here is very encouraging and inspiring. As I say that, I must also specially acknowledge Professor Kuti and Professor Fashuba, both of whom are my teachers from OAU as well. We'll be taking this session on fetal anatomy scan based on our observation and relating this to actual practice in Nigeria. That it is time to start to step up our care for pregnant women. It is time to reduce the prevalence of unexplained stillbirth in our delivery suites. Because in actual facts, if our assessment in the prenatal period has been painstaking, then many of these stillbirths that we declared as unexplained will probably be explainable. So 3 of us will be coordinating this session, as has been rightly introduced, myself, Dr. Enabudozo, and Dr. Mrs. Janet Akimoladu. Dr. Enabudozo from the University of Benin Teaching Hospital, and Dr. Akimoladu from the University College Hospital, Ibadan. We have 2 hours for this session, and we've designed this program in such a way that it encompasses a review of current practice in Nigeria, live demonstration of a normal anatomy scan, introductory lecture to what we should look out for and how we should do an anatomy scan. And if time still permits us, there will be another live demonstration of a woman who is kindly given her permission to be used for this demonstration, in whom an anomaly has just been, a structural anomaly has just been recently diagnosed. I hope that we will have a fulfilling 2-hour session as we proceed in this. I want to invite Dr. Janet Akimoladu, who will be taking the first session of the presentation, to commence her presentation. Thank you.
Good morning, everyone. My teachers from the Obafemi Awolowo University Teaching Hospital, I really appreciate you. I'm also glad to be your midst. My senior colleagues, my colleagues, and the junior colleagues, I welcome every one of us to this session. So I'm going to be, in the next 25, 30 minutes, I'll be taking the talk on the fetal anomaly ultrasound scan in Nigeria. What is the current situation? So I've been introduced. I'm Dr. Janet Akimoladu, a senior lecturer and consultant radiologist from the University College Hospital, Ibadan, and the University of Ibadan. And I'll be using this outline to discuss what is I will introduce the topic and talk about the current situation in Nigeria. What are the factors militating against fetal anomaly scan services in Nigeria? What has been done so far? And a little bit about my UCH experience and what is the way forward. Congenital anomalies that as we all know, are abnormalities of structure, function, or metabolism that is present at birth, with the possibility of causing physical or mental disability on the baby. And according to the World Health Organization and some other sources, major congenital anomalies affect 2 to 3% of infants worldwide, making it the leading cause of perinatal morbidity and mortality. And literature has shown that a greater proportion occur in the developing countries and communities where consanguineous marriage is rife. It's also estimated that 20 to 30% of global neonatal deaths are due to congenital anomalies, with 95% of these occurring in the low and medium income countries. Congenital anomalies are divided usually into two. We have the minor anomalies and the major anomalies. The minor ones are those ones that are present at birth, but they have minimal effect on clinical functions, although they may have a cosmetic effect. Major anomalies are those ones that are severe enough to reduce life expectancy or compromise normal function. And this one could be either severe or lethal. It is a severe anomaly if the newborn infant cannot survive without medical or surgical intervention, and it is lethal if the defect causes stillbirth or infant death with or without intervention. The etiology of congenital anomalies is not known in about close to 80% of cases. The cause is usually unknown. And this is the reason why early detection has been the mainstay of prevention in the developed world. But most of them we don't know the cause. If we know the cause, we know how to prevent it, but we don't even know the cause of most of these anomalies. Prenatal diagnosis of fetal anomalies has come to stay. In the past 4 decades, it has profoundly affected perinatal care in most developed countries. And this is due to the advances in the fetal imaging techniques like 2D ultrasound, which is the main imaging modality that we use for fetal anomaly scan, 3D Doppler ultrasound, fetal MRI. This really gives accurate antenatal detection and enables the parents to make choices once the anomaly is detected. So what is fetal anomaly ultrasound scan? The detailed obstetric ultrasound scan for evaluating the whole anatomy of the fetus in utero. The prenatal screening for fetal anomalies is usually done in the mid-trimester between 18 and 22 weeks gestation. But in the developed world, it's now being done earlier, between 11 and 14 weeks. And if anything is detected and they're not too sure, then you ask patients to come back for the routine one. This is because some anomalies are now being nearly always detectable in the first trimester. That's one that 100% you'll be able to detect it in the first trimester. One should actually note also that many anomalies may be too subtle to be detected early. So that is why the 18 to 22 weeks anomaly scan period is still very valid. So when you detect an anomaly in a baby, in a fetus, what next? The first thing you have to do is to determine the type. Is it a minor one, the major one? And the nature of the anomaly is explained to the patient with or without the partner, depending on how or who came. Some of them will come here, and the other will not come. And this is done by the managing obstetrician, consultant obstetrician. Patients are counseled. If it's minor one, they are reassured. If it's a major one, patients are usually counseled. The severity of the condition is explained, and 2 options are usually often offered. That to continue, to terminate the pregnancy. But the decision to terminate is largely taken by the couple. Then if the patient decides to continue the pregnancy, there's prompt referral of the case to the case to a multidisciplinary team. This multidisciplinary team comprises of the obstetrician, radiologist, geneticist, pediatric surgeon, psychologist, specialist nurses. In some cases, we have pathologists. So depending on the team, the various hospital. Then the decision to put then also, once patient has decided to continue with the pregnancy, delivery of baby is planned. The mode of delivery, time of delivery, the place. And the patient needs any therapy, this one will be also determined. Then if you find out that where the patient is presently located, the hospital where this was detected, there's no availability of neonatal intensive care unit, then such patients are referred in utero. That is, the mother is referred to a setting where these services are available. Then if the mother decides to terminate the pregnancy, she's counseled on the consequences. It could be emotional or psychological, depending. Then allow a safe therapeutic abortion by specialists. Then consent for autopsy and genetic studies are taken. And why this? To confirm the anomaly and to determine the risk of recurrence of the anomaly, because this one will help in the counseling of the patient. If you know that if you're able to do genetic studies, you're able to tell the patient whether the pregnancy, the anomaly is someone that is recurrent or one that is just one-off. It does not continue with subsequent pregnancy. Then the patient is supposed to see a psychologist and then see its follow-up clinic to plan subsequent pregnancies. So what's the situation in Nigeria? While prenatal screening services for fetal anomalies is well established in the developed countries of the world, these services still remain poor in many low and medium income countries, including Nigeria. In a study done by Nabudoso et al. In 2019 on the availability of ultrasound services and training Department of Obstetrics and Gynecology in Nigeria. In this study, 20 federal teaching hospitals, 16 federal medical centers, and 4 state specialist hospitals were studied. And all these centers span the 6 geopolitical regions of the world. And it was found out from the study that majority of the centers have optimal capacity of providing ultrasound training and services in obstetrics ultrasound. From the study, found that only 17 of the surveyed obstetric units had functioning departmental ultrasound machines. 8 had at least 2 functioning machines, and only 5 centers had functioning transvaginal probes. Only 4 of the centers, that is 10% of the centers, had written protocols for antenatal obstetric ultrasound scan. And 24 of the centers reported not having a consultant or resident doctors with any form of practical ultrasound training. This is just a table from the study showing the most important problem, and that's that they encounter. This one is, as I've noted, says on availability of protocols on obstetric ultrasound services. Many institutions, many obstetrics units don't have protocols. Another study by Akimolado et al. On the attitude and practice of medical practitioners towards prenatal ultrasound screening for genital anomalies. In this study, 77 specialists participated from the 6 geopolitical zones of Nigeria. 71% were consultant obstetricians, 29% were resident doctors, and 63, which is 81%, work in tertiary institutions. And this is the distribution of the participants. And we had some from Ghana, but at least the ones from Nigeria, all of them came from the different, we had represented from all the 6 political locations in Nigeria. And from this study, we found that only 10 of the participants refer patients for routine anomaly scans. 54 reserve the referral for only high-risk pregnancy. Some don't even refer at all. 65 of them, which is 84.4%, practice in hospital where there were no protocols for communicating results to patients or referring physicians. And 69 had no protocols at all for managing prenatally diagnosed anomalies. And 69 had no protocol for therapeutic intervention cases of congenital anomaly. The termination of pregnancy for fetal anomaly at a wide spectrum of gestation is possible in many developed countries. For example, in England, Wales, and Scotland, termination of pregnancy for fetal anomaly is legal under the Abortion Act of 1967 with no upper gestational limit. In South Africa, termination is also performed at any period of gestation. It's agreed by consensus that continuation of pregnancy will result in a severely handicapped child. Termination of pregnancy for major anomalies is very not an acceptable option in most developing countries of the world, including Nigeria. Studies have shown that only 32% of countries in the developing world allow it. And this is because we have restrictive abortion law and lack of expertise and facilities. In a study by Nabudoso et al. On the attitude of Nigerian women to termination of pregnancies with major congenital anomalies, 356 pregnant women participated in the study from the University of Ibadan and University of Benin Teaching Hospital. More than half of the participants agreed with termination of pregnancy with major congenital anomalies. And two of the reasons, which are the major ones, was that we want to avoid bringing a child to the world to suffer, and also to prevent wasting of resources, time, and money. This is a table just showing the responses of the mothers. And those who actually agree that they will not terminate, those that disagree with the termination of pregnancy, and this is also what they say, some of them say they trust God for a miracle. Then in this same study, by Akimodo et al. On practitioners, 79.2% of the specially supported therapeutic termination of pregnancy with major anomalies, and 73, almost every one of them had knowledge about the abortion law in their country, that although they would have loved to be doing it, but the abortion law is restrictive, which is reserved only to save the life of the mother. So what are the factors militating against prenatal screening for ultrasound in Nigeria? You know, in a study that was, actually a review article by Anomalies and Anumba, we were able to highlight some causes, some factors that are militating against the services of prenatal screening for anomalies in Nigeria. And some of them are lack of standard coordinated healthcare policies regarding the provision of prenatal screening and diagnostic services. Also, restrictive abortion laws and lack of abortion services. Low level of health education, some women don't even know about it, they don't know about anomaly. Inadequate training opportunities as well as scarcity of trainers on anomaly screening. And lack of access to ultrasound facilities with high resolution, the paucity of training on purchased ultrasound machines. Also, lack of ancillary services. From the study I found, I said the ability to make complicated fetal diagnosis is a waste if there's no physician or facility to treat the patient, if there's no facility or clinician or facility to treat the patient. So there's lack of standardized guidelines for management of prenatally diagnosed fetal anomalies. And there are limited availability of services of specialists in genetics. Very few neonatal intensive care units dedicated. Although we have a lot of pediatric surgeons, but unless they know, many of them are not involved in the management of these patients. So what has been done so far? We have started some training. Some of us, there's been some trainings in Nigeria, training specialists on obstetric ultrasound. We've been trained. So as far as I know, two of the training centers, we have UBTH and UCH, we've had some training in obstetrics and gynecology ultrasound, in obstetric and ultrasound. UBTH with Fetal Diagnostic Ultrasound Center, since 2014, I trained over 700 participants from the Gambia, Ghana, and Nigeria. And UCH also started in 2015, and we started we'll be able to train over 200 doctors. And specialists trained are usually obstetricians, family physicians, and radiologists. And in order to ensure standardized training, this training in collaboration with South African Society of Ultrasound in OIG and International Society of Ultrasound in OIG. And because of this, because we're in collaboration with them, they send representatives from time to time to be in our midst. These are just some of the posters showing some of the recent courses that were done in UCH and Benin. Cross-section of some participants during the workshops, training sessions, another training session showing the facilitators and the facilitators. It's also one of our training sessions. And this is ultrasound showing, this is showing participants at UCH Ibadan. Other things that we're also been able to do, we encourage our participants to participate in International Society of Ultrasound ONG congresses. And because we have collaboration with them, they give us discounted fees to be able to attend these congresses. And so far, about 8 of our facilitators and participants have won travel grants to attend some of these congresses. And our Dr. Eiga Enaboto is an Iswap ambassador to West Africa and a member of the Iswap Training Committee. This is a picture showing Dr. Professor Tony Odibo from USA at one of the congresses. This is also another picture showing some of the participants in the last in the congress at Berlin in Germany. And what another that we're able to do, we're able to have collaboration with ultrasound machines vendors, with GE, GNC High, Sonoscape, Vino, and those ones actually release their ultrasound for training. During our training sessions, during the training sessions, they release the ultrasound machines for training, and then ultrasound machines are sold to participants at pocket-friendly instrumental payments. So they pay. Then through this avenue, many of our participants have been able to buy ultrasound machines for their institutions and also some for private use. Okay, these are some of our collaborators. These are GE representatives. This is another representative from Gino, with the presenters of today. So what's it about UCH experience? UCH is a place where we've started screening for fetal anomalies since 2012. Yes, we have a basic, we have a protocol for screening. And since 2012, we've started screening. By 2014, we were able to screen 287 anomalies that were detected. We had 29 anomalies, 14 being major. By 2016, we were able to, from 2012 to 2016, 984, 89. And at now, we've been able to screen 4,880 pregnant women since inception for fetal anomaly. And out of this, we'll be able to detect 106 anomalies, of which 68 are major anomalies. And this was just one of the papers that came out from the study that this one is pattern and outcome of prenatally diagnosed major anomalies at a Nigerian tertiary institution. And one of the things that helped us to intimate the pregnant women about fetal anomalies, we use the patient information leaflets, which is usually given at the booking clinic to all pregnant women, for them to know about fetal anomaly scans, when it is done, and what to expect. So what are our recommendations from this? Fetal anomaly screening has come to stay. And from study, we know that the cause of an anomaly is not known in all patients, in most cases. So fetal anomaly should be offered to all pregnant women. An awareness program should be organized to intimate the populace about fetal anomaly scan services. Then specialized training in prenatal ultrasound screening is recommended for as many as want to specialize in fetal imaging and medicine. Then multidisciplinary approach should be adopted when a fetal anomaly is detected. Then policies and programs should be developed that will incorporate a standard routine screening prenatal ultrasound service. Then termination of pregnancies as an option should be incorporated into our abortion policy for major congenital anomalies. Thank you so much for your kind attention.
Thank you, Dr. Janet Akimoladun, for the presentation and for keeping to time. So we will move in straight over the next 15 minutes. As I told you earlier, it's a cocktail of different approaches. That's Dr. Akimoladun from University College Hospital Ibadan. From there, we'll take a short trip to, well, maybe not so short actually, University of Benin Teaching Hospital, where Dr. Nabudozo will be waiting for a 15 minutes live demonstration of fetal anatomy scan. Dr. Nabudozo, if you are ready, we can take your demonstration, please.
Video hasn't started. Hello all. Good morning, everybody, and greetings from Benin. We're trying to use some strategy here to be able to show a live demonstration that everything works out well. I hope, Ibrahim, are you hearing me?
We can hear you.
I can hear you, sir. Do you want to consider sharing your screen?
Yes, that's what, no, it's a live video. So you're going to put me into your system. That's my own video. You get it? So every person is watching on your screen. You will have to just check for participants and then click on mine so that it shows directly on your video. Have you tried that now?
Well, we can see your screen.
Good, that's what I want. Great.
We can see what you're scanning.
All right, so I'm going to do a live demo of an anatomical scan, fetal anatomical scan. So we're trying to use some extra technology here. So what we're just doing is I will just show it as a video. And then I'll be using the cursor to just show a few things. So for fetal anatomical scan, the very first thing is to do a panoramic view to see what's inside the whole of the uterus, which is what I'm going to do now. Unfortunately, you'll be able to see my hand move, but you just look at the screen. So here is the maternal bladder, the cervix here, and then this is the lower segment. So this shows that this is a cephalic presentation. And then as we move on, we see the baby. We'll get to the fundus of the uterus. So as I said, this is a panoramic view. And then we see the placenta. So the posterior high placenta will come down. So in a panoramic view, we want to have an idea of the whole of the uterus. And having done that, we check the adnexae if there are masses. So I'll do all that quickly. And then we'll now move to the meat of the issue. So having done all that, we'll have answered some of the basic questions. Now for the anatomic detail, it's always good to move from one step to the other. So for this baby now, I'm going to start from the head. And in the head, we want to look at the shape of the skull. So Ibrahim is going to be telling us some of the things that we're going to look out for. But again, because I'm afraid so much of how technology may fail, I said, let me do this first. Then after his talk, I'll do a second one. So this is the fetal head. And in this, we look at the skull, the shape of the skull. This is an oblong shape or oval shape. So this is normal. And then we'll go to the appropriate view. This is the transventricular view. So we'll see the ventricles. And then we can actually freeze at this point. With this view, we can assess so many things. We have looked at the skull. We can look at the brain. This is the cavum septum pellucidum, the falx cerebri. So based on all that, we have a reasonable idea that this is the right plane. We see the ventricles here. So usually you will measure the ventricle. Ventricle should be less than 10. This is about 3.3 millimeters. So that's normal and it's fine. Then you do the parietal diameter measurement from outer to inner. I'm going to save time by not bothering to measure that. Then the head circumference as well. So let me just quickly do that just to demonstrate it. So we measure the head circumference. And then we're able to have a reasonable
I think Dr. Navidozo may be experiencing some glitches. We'll give him a few minutes, hopefully he can come back on.
Dr. Wale.
Yes, ma'am.
Yes, maybe while he's trying to get back, maybe you can still provide some, like an outline of the main landmarks and
yes,
the main, so just to fill in.
Thank you, Ma. I think what we'll probably just do is that I will start my own session, which will take us about 45 minutes, and hopefully by the time I'm through, you will have sorted out the issues there. We were actually anticipating this may happen. So I'll just move to my session in a minute. Thank you, Ma. Can everybody see my screen? I'm sharing my slides now.
We can.
Yes, we
thank
can.
you. Oh, great. So while we wait for Dr. Navidozo to sort out that bit, I will just go on with the presentation. As I'm introduced earlier, I'm from the AFEMSON University, and I appreciate AFEMSON and the president and the executives for this opportunity to spread this message around. So I hope we didn't leave anybody behind at Benin, because now we're at Ife. We're kind of shopping all over the country now. So I welcome everybody to Ile-Ife, the source, where we'll be introducing us to fetal anatomy scan. So the outline will be to understand what the aims of fetal anatomy scan, what the aims are, who should have the scan done, who should be doing it, when can we do it, and how should it be done. And the aim is to encourage and support different centers that are yet to start to do this, to kickstart it. We may just realize that it may not be as difficult as we had all thought it could be, and to also encourage collaborations within centers. Thankfully, Dr. Mrs. Akimolade has done a very good job preparing the ground for the rest of the discussion. So fetal anatomy scan aims to assess for any anomalies, whether structural, functional, or metabolic, before delivery. And if it is normal, it provides that reassurance on anatomical normality. Again, if any problem is detected, it provides room for counseling and an opportunity for designing a plan of care, including decisions on where the baby should be born, how the baby should be born, and what should we do for the baby. I think an important part that may often be overlooked here is the time that it provides for psychological adaptation. It takes away the surprise factor. The parents already know what to expect, and indeed, they adjusted their psyche into keying into the necessary care for that baby at delivery. And importantly, doing an anatomy scan provides a basis, which is objective, for the continuation or termination of pregnancy, which is by no means a small decision for many families. We should have an anatomy scan done. As discussed earlier, over 3/4 of fetal anomalies actually do not have a known etiology. Of course, this is not without a caveat, because it depends on what facilities are available in that setting for investigations of metabolic and genetic contributors. And so it is difficult to tell who will have a structurally anomalous fetus or otherwise. And as such, The answer will be everybody. All pregnant women should have an anatomy scan done. Who should be performing it? This is also important for centers that are planning to start a program and for centers that are already doing it. One key factor is the requisite training. Whoever is doing this must be appropriately trained to perform the procedure and must not only be trained, but in fact must be regularly performing it. And that's because it's such a procedure that is easily, the operator can easily get de-skilled. If you are not doing it regularly, you can lose the skill. So whoever has gone through training must enjoy support to ensure that they continue to perform these procedures. And they must, of course, regulate and update their knowledge. It's a dynamic field. There must be access to appropriate referrals for suspicious or abnormal findings, and there must be quality assurance and control measures. Sometimes things may go wrong, diagnosis may be wrong based on which decisions have been taken. It is important to ensure that such situations do not happen a second time or in fact repeatedly, and this calls for institutional audit as well. Ultrasound equipment. We say it a lot repeatedly that in performing these procedures, there are 3 T's. There is the technology, there is the technique, and there is the technician aspect of it. The technician aspect is so important because that's the person that brings the technique to the technology. And so while technological advancements, including the use of color Doppler, power Doppler, 3D, 4D, and spatiotemporal imaging correlations can be done, it is important to know that the basic requirement for performing an anatomy scan is in fact 2D ultrasound. If you have a 2D ultrasound, we can make many diagnoses that would otherwise have been missed, and we can continue to build on that. And I'm emphasizing this because I've spoken with a number of my colleagues who are interested in doing this, but who continue to hesitate because they've not had the millions that are required to buy the machines with the resolution of their dreams. While we await that machine, it's important to start doing something, especially for the purpose of being able to demonstrate the skill and update our skills. When should an anatomy scan be done? Organized training program is standard in places like the United Kingdom, and the optimal time for that is between 18 to 20 weeks plus 6 days. This gives room to assess many of the anomalies. It's important to know that up to 50% of anomalies that are diagnosed in the UK at the moment, though, are diagnosed in fact before 14 weeks, such as anencephaly, gastroschisis, omphalocele, because these are very obvious. And in women who have had previous risk and have been assessed for sibling risk, they can also be assessed even before 18 weeks. But almost always, if the pregnancy is not terminated, a repeat assessment is done at this time. And that's because Dr. Akinoladu had beautifully informed us that some of these anomalies continue to evolve and become manifest as gestational age advances. Even in the best of hands, a lot of these anomalies can still be missed. And so there is always a call for caution. There is always a need for disclaimer. Whenever a report on anatomy scan is written, we only write on what we have seen and what has been assessed appropriately. Because we look at a condition like diaphragmatic hernia, in the best of hands, 60% benchmarked detection rate. It means 40% may go undetected. And serious cardiac anomalies, up to half of serious cardiac anomalies are in fact not detected, even in the best of centers. And this is why whenever reports of anatomy scans are written, we still put some of these disclaimers there. It is always good practice to write about the biometry, placenta, and liquor volume like we would do for a regular obstetric scan when we do an anatomy scan. And usually the report starts with this, because should there be a major anomaly, there's a tendency to spend time assessing and appraising these anomalies And at the end of the day, we get to take biometry and estimated weight of the fetus. So almost always all anatomy scan reports should carry information about biometry, placenta size, and the like of other. Now to the technique. There are different techniques, there are different protocols. Some are more detailed than the other. I was trained with the British Fetal-Maternal Medicine Society protocol. But I've also seen the Iswap Protocol, which advised the use of 20+2 planes. And if we can be appropriately trained in using this, we will be able to exclude up to 50 abnormal fetal appearances. And so I find this checklist or protocol by Iswap very extensive and easy. There are, however, criticisms of this technique. So they've given 20 planes that we need to check and assess. However, the orderliness is called to question because, for example, many people will rather take the fetus in a craniocaudal fashion during assessment, and that is easier to follow. But when we look at the ISWAG assessment, the first plane is in the fetal spine. And so I also advise that this should be interpreted and used with caution. Nevertheless, it is very extensive and it is a good guide to whoever is starting an anatomy scan. So it looks at the fetal spine in 3 planes, sagittal, coronal, and axial planes. It looks at the head, transthalamic, transcerebellar, and transventricular planes. And these 3 planes are important. Hopefully, I'll be able to show us some anomalies as we move along in this presentation across the different planes. The thorax, cardiac assessment, the lungs, heart, these are very important because, in fact, transitioning from in utero to ex utero environment depends largely on the thorax and its content. And if there is any abnormality here, the fetus, now baby after delivery, benefits immensely if provisions have been made to address such challenges postpartum. 3 planes as well in the abdomen, stomach, cord insertion, and the kidneys. I'll be demonstrating, I'll be showing us images of this fetal bladder, the fetal limbs, and this is the second criticism of this technique because it is ending with the fetal face. Most specialists who perform anatomy scan will start with the fetal head and will immediately assess the fetal face. But as I said, if we take away these limitations, this is a fantastic technique to adopt. Now, this is where Dr. Nabudozo stopped. Hopefully, we'll be able to get him back to do live demonstrations of this. But this is just exactly what he was trying to explain to us. We need to assess the fetal head, assess the cranium, cavum, septum, pellucidum, the midline falx, cerebri, thalami, cerebral ventricles, cerebellum, and the cisterna magna. So this is a lot of anatomy, a lot of big names to remember. We all probably did this last in medical school, but it's not difficult. To be honest, if we set our minds to it, as I'll be showing us now, we'll remember this image on my left shows the cranium of that fetus, as Dr. Nabudozo was trying to show us. There is this rectangular box there, that's the cavum, septum, pellucidum. There is a white line in the middle here, and that's the falx cerebri. And this tuft of tissue, the whitish area here, is the choroid plexus. And the choroid plexus is where CSF is secreted from, as we can see CSF collecting here in the posterior horn of the ventricle. And this measurement was exactly what he was doing when there was that glitch. And so this represents what a normal fetal head should look like. And this plane, because it is showing the ventricle, is a transventricular plane. On the other side here is a fetus I met not long ago. And what this is demonstrating is what we call ventriculomegaly, which is dilated enlarged ventricle. So normally, anatomically, the choroid plexus fills up the ventricle, but here because the ventricles are dilated. We can see the collateral plexus just floating freely there. It's not a lethal condition. Some of these babies, when delivered, may need some support as they start school. But again, the proportion of those babies are small, probably about 1 in 20. Usually they do well. We're co-managing this with the neurosurgeons at the moment. This is an encephaly, and here, as we see, another anomaly of the fetal cranium, the brain is exposed. That's the frog sign there with the eyes prominent on the fetal face. I took a 3D image of this because I was trying to explain to the mother, and she found it a bit difficult to understand. And so I chose to go to 3D mode and showed the mother the absence of the fetal cranium, although we could see the face. And after extensive discussion on this, she resolved to terminate the pregnancy, and that was exactly what we did. This was at about 20-week gestation. Moving on to the cerebellar plane, which I
Hello,
spoke about.
Ibrahim. Hello.
Yes, Dr.
Hello.
Enabudozo, are you back?
You know, with this very unreliable network, I will plead I'll be coming intermittently because it rained very badly in Benin. We've used all the networks this morning to get prepared for this. Now that we have a little time that it seems a bit stable now, maybe I'll just do a little. If it goes off, then you continue. If there's a way we can do it. Hello, are you hearing me?
Yes, I can hear you, sir.
Okay, we can do that. Then maybe you can pause your sharing of your screen now so that I can come in. Now that it seemed a bit stable for a little while because it comes in and on and off. Is that
okay? Thank you. Yeah, that's fine so that we can quickly take your own parts since you have stable internet now.
Yes. All right. So you can stop your sharing so that I can use my video to show. Good. All right, so I apologize. It's it's network issue. So this one where we stopped. So we're showing the cerebellum here. So this is cerebellum, the butterfly-shaped cerebellum. And then behind it, we can check for the cisternum magnum. And then after that, the skin fold thickness. All these have implications. Cisternum magnum, if it is so small, then that could also give us an idea that there may be a structure, open spinal bifida, neural tube defect, really. And then the knockout fold thickness could also give us an idea, as we used to use as a screening tool, really, for Down syndrome. All these here appear normal. So I won't bother measuring them, so we can move on. So this was where, so you can see this baby has, I just turned now. So that's the cerebellum there. So moving on from there, still around the head area. So usually for most guidelines, once you can do this, you can reasonably say that the brain is okay in a very large percentage, because looking at the cerebellum, on the cerebellum too, remember that you have the body of cerebellum and then the vermix. So you look at the vermix down, look at the fourth ventricle just in front of it, and then the cisternum magnum that I've already talked about. Then the next thing, usually before you leave the head, you want to look at the face. Sometimes it's easier when there's a large pool of liquor around the face so that you can see. So for this now, the face is almost plastered to the wall of the uterus, but I will try to see the nostrils. So if we look very carefully, you're going to see some pinpoints here. These are the nostrils. So this baby has two nostrils. And then if you see this straight line here, that's the lip. So that excludes a cleft lip. Then we now want to look at the palate. If you look at this small opening here, that's the mouth of the baby. So sometimes the baby open its mouth and then you'll be able to see that better. And then as we move on, most times we're able to also see the mandible. That's the alveolar ridges of the mandible. This is the tongue. So you can see the tongue moving. That's the tongue. Good. So the baby just understood us. That's the tongue moving. And then that's the mouth. So at this point too, if also the baby gives us a good view, you want to have a facial profile. So that's a facial profile. So on the facial profile, you can also see the mouth opening here. This is the nasal bone, so which you can measure as well. Then the maxilla, then the mandible. In this mid-sagittal view of the face, you're able to see the mandible, and you can see that this mandible looks okay. In certain abnormalities like the pierrobin, you see that the mandibles are small. So most times this is what the mothers enjoy because they can actually see the baby's face.